So thank you so much. And after that little provocative talk by Jibin, I think it's good morning to everybody. I'm going to switch gears and talk of clinical pearls from diabetes mega trials, what clinicians should know, and what's the evidence base around it. These are my disclosures. For this talk, there are none, but my mandatory disclosures are all up here. Why I chose this topic is because outcomes RCTs teach and rapidly disseminate what does and what does not prevent and or treat diabetes outcomes. And they must be interpreted in the context of all that has gone before. So clearly, outcomes RCTs is what EBM is all about, and they will clearly impact lives of people with diabetes, make them live longer, make them live with lesser or no complications. We have to take a cue from our colleagues who treat blood pressure. And if you see somebody with a natural history of a 35-year-old Caucasian with untreated high blood pressure, and if you keep the blood pressure at 130, 120 over 80, the lifespan is 76, 130 over 90, 72, 4 years are lost. If it's 140 over 95, it's 68, around 8 years are lost. And if it is 150 over 100, almost 16 years are lost. And that's exactly what's happening with diabetes control. If we don't maintain euglycemia, of course without hypoglycemia, we are going to land up with the same thing. Professor B. Mohan is in the audience, but his very good friend and very close friend from Emory, Professor Venkat Narayan, who used to work at CDC and now is at Emory, gave this Kelly West talk. Why are we winning the battle with diabetes but losing the war? The evidence that we are winning the battle is because we are improving risk factors of people with diabetes and declining the rates of complications. However, the evidence that we are losing the war is the global burden of the disease across the world is still on the rise despite of extraordinary prevention efforts. And there's a global explosion of diabetes globally. And in Indians, where we live, we have a dual jeopardy of beta cell dysfunction and insulin resistance both. So when it comes to large mega trials, which are large outcome RCTs, outcomes are necessary and important for patients, healthcare providers, and society. From a biology standpoint, they can be used to justify any effect. Non-randomized studies are always confounded. Small RCTs are not designed for severe outcomes, so high risk of chance finding, and there is a biased ascertainment. Meta-analysis of small RCTs of outcomes magnifies the problem seen with small RCTs, and therefore there is a need for large outcome RCTs, big enough to ensure that the randomization distributes all confounders into two equal groups and at least one of them gets the treatment. That's really the primum, and therefore enough outcomes occur in each group to be confident. And this is not what I say, but this last part comes from Herschel Gerstein, who's the guru from McMaster in evidence-based medicine. When you look at level of evidence, we have different ways of classing it. Class 1, Class 2A, Class 2B, Class 3, which is 1 is benefit more than the risk, 2A is benefit more than the risk with additional studies, 2B and 3. And then there are levels of evidence. For example, level A, multiple populations, pan-world, data from multiple RCTs or meta-analysis. Level B, limited populations, data derived from a single or non-randomized trials. And level C is case control, expert opinions, very limited populations. So therefore, ADA was the first, followed by ESD and many others worldwide now, to have an evidence-based grading system for clinical practice recommendations. And therefore, they follow the A, the B, the C, and the E. E being expert consensus and clinical experience. We have no role for anecdotes here. Then we have the C. Then we migrate to the B, where there is a little bit more supportive evidence from well-conducted prospective cohorts or meta-analysis of cohorts. And then we move up the ladder into the proper RCTs. So very quickly, I am going to quickly dwell upon the first game changer trial on planet Earth was the DCCT trial. No question asked about it. And I'm sure that a couple of speakers will dwell with it, so I won't dwell too much on it. But type 2 diabetes is the space where we saw preventive and care, where UK PDS was a game changer trial. Jibin did mention the three big threes which came in the first decade of this century: Accord, Advanced, VADT. And then we had Empareg as a game changer, and then we had a direct game changer. So let us quickly go through it. I think the first major high impact mega trial was DCCT. And it impacted lives of people with diabetes with vascular complications. It sowed the seeds of the legacy. It's a legacy trial with legacy effect of a follow-up. And everyone matters. Retinopathy, nephropathy, neuropathy, everything came down. Of course, the trade-off was 2 to 3-fold hypoglycemia. What is compelling for DCCT is the most youth with type 1 diabetes should be treated intensively, hit hard, hit early. Risk of progression to retinopathy and development of microalbuminuria came down. And the birth of legacy effect came from the EDIC cohorts. And last year at the ADA, there was a very, very elegant presentation on the follow-up of EDIC, very clearly documenting that better is the insulin control. And you will get a speak by Dr. Vigarsi, who's here, who will tell you the data points on that. So I'm not going to go into the AIDs which are coming in. I'm moving gears from type 1, which sowed the seed of legacy effects, into the prevention mega trials. And in the prevention mega trials, we had Daiching study with a 30-year follow-up, documenting lifestyle works. We had the Finnish DPS as well as the DPP from the United States, funded by NIH and Finnish trials, clearly documenting lifestyle works. And then we had the Indian DPP coming from Ramchandran's group, and finally Dr. Mohan and Dr. Venkat Narayan came out with the DCLIP trial. And you can see that data point of the DCLIP trial from the Indian population again. So in the type 2 prevention space, we have some data points which are there. What do these prevention mega trials teach us, whether it's a Daiching or a DPS or DPP4? That lifestyle interventions can significantly reduce, as a clinician, type 2 risk across diverse populations, whether it's a China, Japan, India, or United States, or Caucasians, Africans, or Asians. It has a global impact because it is the basis or foundation of national or international type 2 diabetes prevention programs. The benefits are sustained if the lifestyle intervention is early. It can delay or progress type 2 diabetes onset. And the challenges are implementation. And therefore, we need to build on the success of these trials so that we can have adapted, proven strategies in diverse settings. That's the key. So that was my second point. The foundation trial of mega trials in the type 2 diabetes space is UKPDS. Conceived in the years of uncertainty of the termination, which was premature, of the UDGP program in the late 60s. It appeared to demonstrate excessive cardiovascular mortality with tolbutamide, with excess all-cause mortality with fenformin. And therefore, there was a need felt that you should have a trial in primary care with possible utility of early insulin treatment, which was commenced in December 1977. You will be surprised to know that it was a very small grant from the Cloth Workers Foundation. And late Professor Turner and of course Professor Uri Hallman gave a very elegant Banting lecture last year, clearly documented with that little small grant that started this whole premise. They picked up patients, 5,000, ran for 20 years, 23 UK sites, looked at a progression and natural history of the disease for glucose control and blood pressure control. And as I said, it was designed and run by Professor late Robert Turner and Professor Uri Hallman. The trial phase covered nearly 43,000 person years from 1977 to 1997. The post-trial monitoring captured around 67,000 person years of data from 1997 to 2007. And from then, the NHS data of UKPDS participants accumulated a net wealth of 78,000 person years. And this was very elegantly presented 2 years back at the ESD of the 44 years of UKPDS. The patients were 25 to 65, 80% white, 10% Asian Indians, 9% Afro-Caribbeans, quarterly visits in UKPDS clinics, and they had an intensive arm versus a conventional arm. The A1C came down from 7.9 to 7 over 10 years. Any diabetes related endpoint 12%, microvascular disease 25%, MI 16%. And therefore, this was something very compelling in that UDGP era. And they were embedded hypertensive patients, and just improving blood pressure with an ACE or a beta blocker then reduced risk of both micro and macrovascular events, which got submerged because we only keep talking about the glucose-centric data and there were no extra staff costs involved. So over the time, intensive glucose control with SU or sulfonylureas or insulin versus conventional patients early in the disease clearly showed an impact, and this NEGM paper of the 10 years showed that after 20 years and 10 years, you could see the benefits of early tight control from the UK PDS. And when the post-trial monitoring closed out and was presented at the September 2008 ESD meeting, the data was very, very clear-cut. For brevity of time, the blood pressure data is as compelling as the glucose data. The tight versus less tight blood pressure control, but there was no legacy effect there. But in 2022, at the ESD, they presented the legacy effects of the trial, which means implementing intensive blood glucose strategy after diagnosis continue and persist after 44 years. 11% fewer deaths, 26% fewer diabetic complications like kidney failure or vision loss, and early intensive blood glucose control with metformin led to 31% fewer heart attacks and 25% fewer deaths. Very, very compelling high impact data with an extraordinary follow-up, which is something there, and this is exactly what is extrapolated in these slides. And if you look at the 44-year follow-up of quality of adjusted life years, you could clearly see the impact of it. And therefore, when you look at UK PDS at 2030, this is how it would probably look at in the future, and the legacy effect is extrapolated. So clearly, inadequate glucose control induces irreversible pathophysiological damage, propelling risk of complications and early death, and that's something which we need to recognize. And therefore, the key message is diabetes complications are not inevitable, glucose and blood pressure control matters, and legacy effect is very, very compelling. So what did these two mega trials teach us? DCCT EDIC, UK PDS and long-term follow-up clearly told us metabolic memory is there. Good glycemic control matters. Almost similar timelines of publications in high-impact journals. The New England Journal is probably the highest impact journal, clearly imprinting this whole biology of metabolic memory, both at macrovessels and microvessels, on atherosclerosis and microangiopathy. And you can see that Antonio Cirolio, who was here, clearly showed this metabolic memory is not just tight glycemic control. It's much more than that. And you can see here the graph. The green shows that the lower the A1C, the hazard ratio on all-cause mortality or microinfarction is better. And as every unit of A1C goes up, you can see growing up the. So the simple take-home message was, don't generate in the first decade of a diabetic's life bad glycemic legacy, because that drives the risk of complications. Hit hard, hit early. And that was the second take-home message which we get from the mega trials. But this was with early glycemic control, not late glycemic control. Duration of diabetes less than 10 years, you have DCCT, you have UK PDS, you have STENO2, you have Kaiser, you have TACHO, and many others, which impact microvascular and macrovascular health. But if it is beyond 10 years of duration, we had a stumbling block. Whether it was advanced or accord, and in macrovascular space, no evidence. And therefore, we drew blanks. We clearly drew blanks, including the proactive study. We clearly drew blanks here. So a lot of explanations came out from these mega trials, which had neutral results from contemporary glucose-lowering trials. Because many of these trials, in the first decade of 21st century, which is between 2000 and 2010, had short periods of follow-up. The endpoints needed revision. Resources were demanding and costly. Study populations with cardiovascular damage, long-term benefits and risks were not elucidated, and few head-to-head comparisons with available drugs. There were no firm endpoints, surrogate markers were insufficient, and they were mainly driven by regulators and market forces rather than academic scientists. Unlike UK PDS or DCCT, which was driven for a different purpose altogether. If you look at the entire space of studies conducted when glucose-lowering drugs with proven cardiovascular benefits were there, UKPDS was not in the era of SGLT2 inhibitors. So my question, a research question which I asked the audience here is, if you introduce SGLT2 inhibitors, will it attenuate the legacy effect? Will it make an impact? It could. This is extrapolation of data that if you have a background metformin, an SGLT2 inhibitor could drive it. And then came another game changer trial, and that's the last trial I'll allude to and then maybe direct. For brevity of time, the EMPA-REG. EMPA-REG clearly changed the way we think. It's a very, very high impact trial, and you could see that the 3-point MACE separated very, very early in the curve. Nobody knows the answer, everything is hypothesis generation. But this trial clearly showed that on the 3-point MACE, whether it's intention to treat, on treatment, per protocol analysis, the data was clear cut. Cardiovascular death came down, all-cause mortality came down, and summarizing very clear data, very compelling data, heart failure, CV death, and all-cause mortality came down. Very, very compelling data. Compared to a simvastatin or a ramipril, you could see that you could clearly see that EMPA-REG was the next game changer trial which changed practice guidelines. Clearly we saw that, and you could see that the outcome driven was very clear. So it was a classic example of a good outcomes RCT. Did it have a good protocol? Yes. High retention, high adherence, high event ascertainment, clear analysis and presentation, raised more questions than answers? Yes, to everything. Clearly you can see that it was a game changer trial, and it drove guidelines and recommendations across the world. And if you see now, any guidance across the world, whether it's AD, ESD, atherosclerotic cardiovascular disease, CKD, heart failure, came right up the order from glycemic control. So the gear did change. And I'm not going into the GLP-1 gear here because we don't have compelling data for the same. Now though data has started coming up. The EMPA-REG was a game changer. It clearly identified people who could save many more lives, reduce suffering. Results were unexpected. It opened up new research avenues, and there is a space for diabetes care, because diabetes care is one space which has the most evidence-based practice. If you look at oncology care, it's on very flimsy grounds of mega trials. Still, big ticket drugs are marketed. But if you look at diabetes care, we have a very high level of evidence, and therefore better glucose strategy and better cardiorenal strategy is very much here. Professor Roy Taylor was very disruptive. He showed that severe caloric restriction has the same effect as bariatric surgery, and he clearly showed in the direct trial, again done in primary care, that he could resurrect the first phase of insulin secretion. And in primary care, he showed for people who had diabetes duration less than 6 years, not receiving insulin, at least half of them, he was able to do diabetes remission. And he published his 5-year follow-up last year, which is extended direct intervention, which had a lesser weight loss and better health status. So remission is a practical target, and this is the 5-year direct follow-up. Professor V. Mohan is in the audience. He did the ICMR INDIAB. He used a compute modeling, and he showed in his paper, and many of us were a partner with that, that you could reverse diabetes just by cutting carbs and adding protein intake, and we try to do various technologies. So with brevity of time, all I wanted to teach in this session was that outcomes RCTs teach and rapidly disseminate what does and what does not prevent or treat diabetes outcomes. We need to interpret them in the context of all that has gone before, because they will impact of lives people with diabetes. We need to make them live longer with lesser complications or no complications. And please look at the science and evidence base and the level of evidence, and mega trials prove us their answer. So mega trials clearly teach us the diabetes prevention space, there are mega trials. In the diabetes remission space, there are mega trials. And in reduction of progression and cardiovascular outcomes or cardiorenal outcomes or liver outcomes, there are also mega trials. So I think in each space, we are having interventions which are well designed, which are pan-world, which are not just geography-centric or ethnic-specific. One more thing the mega trials teach us is lifestyle is supreme. Whatever you may do, no drug can challenge lifestyle. Lifestyle needs to be interjected in the prevention space. May not be in the therapy space, but needs to be interjected in the prevention space, because no other drug could pip lifestyle in the prevention space. That thing is very, very clear cut. When it comes to intervention space, probably interventions are evidence based, and that's something which we recognize. Thank you so much for a patient hearing.